Hi, this is Brian Kim. I'm going to share with you case number 192 in the Best Way to Do Cataract Surgery series. This is a patient with a Catarock, and you'll see that when I start the case. And now I'm going to perform terminal chop, cross chop, and leverage mechanical fracturing techniques in order to crush the lens between the instruments into smaller and smaller pieces. You're going to see hooking the peripheral lens with the chopper and positioning the phaco tip deep within the bag. And this allows you a more effective complete chop, and this helps you avoid and bypass the posterior plate phenomenon. No more wound burns and no more post-occlusion surge and the risk for posterior capsule rupture. You can see this is a rather dense cataract. Look how cloudy the view is. I'm using the cotton tip to steady the eye. Use a corneal marker, which will help me to center and size a rhexis. And then I'm making paracentesis incision first on the right side and then the left side. I'm using the cotton tip to control the eye so I can get a nice flat approach parallel to iris plane. And this creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You can see this is the right eye. This is intracameral epinephrine, and then some intracameral air for the trypan blue. Here's the trypan blue. The air bubble didn't stay very well, but I'm going to try to paint the anterior capsule surface and try to use minimal amount of trypan there. This is some dispersive viscoelastic to push the dye and the air bubble out, but also to coat the corneal endothelium and flatten the anterior capsule. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, using the cannula to control the eye, and then I enter. So this is a cool technique. I'm going to use that cannula to push more viscoelastic simultaneously as needed during the rhexis. And so that's an important pearl and tip. You can use the cannula with the viscoelastic. Again, you already have the dispersive viscoelastic. Why not just use it? I hold the eye, and this gives me control of the eye, but also allows me to push more viscoelastic. So I puncture the center, create a nice tear pointing and pulling down, grabbing the right side of the tear, going around circumferentially, and I have great control, 2-point fixation with the cannula and the rhexis forceps. And again, if I feel like I'm going to get a run out, I can push some more viscoelastic simultaneously. Finish off the rhexis, burp some viscoelastic out. And this is the capsular fornix hydrodissection technique. I'll place a cannula under the rhexis edge contra-incisionally, point the tip down. Get a nice wave, decompress on the left side, sweeping under the rhexis edge along the left side, and the lens begins to spin. Oftentimes, these really dense lenses tend to have loose lenses, and that's partly because there's so much liquefaction and there's hardly any epinucleus in these cases. This is the opposite of the sticky lens. Adjusting the sleeve. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. With bevel down, I'm removing the surface epinucleal material, and I turn bevel up and I begin the sculpting. And this is a dense setting that I'm using. Go ahead and start sculpting. I don't have to make a really long trough. About the diameter of the rhexis is fine. Widening just a little bit as I go. And you only want to apply ultrasonic energy moving forward. And I'm just very ginger, making sure I'm debulking the center mostly. You want to debulk the sides as well, but really you want to concentrate on debulking the center. And you can see, look at the CDE, it's going up crazy. And that's because I have to use a lot of ultrasonic energy, in particular longitudinal in this case. I'm turning bevel up now. I feel like it's deep enough. I switch to quadrant mode, placing the chopper under the rhexis edge contra-incisionally with the tip leading, getting it out to the terminal side, fracturing the terminal side against the phaco tip, and that fracture propagates through and through. This is how you avoid very easily the posterior plate phenomena. Placing the chopper around the right heminucleus, hooking the peripheral lens, and keeping the phaco tip deep in the bag for a complete chop. Placing the chopper around that second quadrant and performing the same maneuver again with the phaco tip deep, and the phaco tip acts like a chopping block, grabbing that fragment up, crushing the lens between the instruments, and then emulsifying the lens piece. Again, grabbing that other piece up, hooking the lens, and crushing the lens between the instruments completely, and then emulsifying the lens piece. You can see, even though I did a complete chop, it's still jigsawed together. Go ahead and separate that second quadrant from the rest of the lens. Again, sliding under the lens, hooking the peripheral lens, crushing it against the phaco tip with another cross chop maneuver. Placing the chopper again around that fragment, pulling it up, and then fracturing it completely as well. That's the benefit of placing the chopper around the lens. Not only can you get a through and through chop and you're holding the lens from the other side, you're not causing any zonular stress or anything, but also you're able to lift it out of the bag, which makes access much more easy. Placing the chopper around that fragment once again, fracturing it against the phaco tip. Once it's loose and broken up, grab it with some vacuum, crushing the lens between the instruments and emulsifying the lens piece. So again, using crushing force to utilize less ultrasonic energy. Turning that second heminucleus in front of me, placing the chopper with the tip leading off, hooking the peripheral lens. Look how deep that phaco tip is, fracturing the lens completely in half through and through, performing the same maneuver around the third quadrant, having that phaco tip deep. That gives you that complete fracture point. Again, the phaco tip is acting like a chopping block. Using some vacuum to lift that first piece up, chopping the posterior aspect, that was a scissoring chop maneuver, amputating that piece and turning the chopper sideways. Using some vacuum to grab that piece up, again, fracturing the lens between the instruments, and then emulsifying the lens pieces. Again, utilizing mechanical fracturing to break the pieces into smaller and smaller pieces decreases your risk for wound burn as well as post-occlusion surge. Turning that last quadrant in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it centric toward the phaco tip, which is deep in the bag, and then the lens is broken completely in half. Doing the same maneuver around that fragment, see the lens is turning, but it doesn't matter, it's no big deal. I'm able to hook the peripheral lens, crush it against the phaco tip once again, and making sure that the pieces are completely separated, and then using some vacuum to grab that fragment, getting around it with a chopper, crushing it into smaller pieces, and then emulsifying the lens piece. By always going after the piece with the chopper and hooking the peripheral lens, I never struggle. I don't have to go after it and then, I can't get purchase and the vacuum won't hold it. And then you try to like lollipop it with ultrasonic energy and it doesn't come to you. There's just a lot of inefficiency and frustration when you do it the traditional way of trying to grab pieces. By hooking the lens with the chopper peripherally, you're just pulling it up towards you, which makes a lot of sense because it's stuck within the bag. So just use a chopper, get around the lens, and then now you have opposing forces, and you can crush the lens very efficiently between the instruments. Now, oftentimes with these cases, there's no epinucleus, as you can see here, and there's hardly any cortex. So it's very, very important to protect the posterior capsule because it can come forward. And so you can see mechanical fracturing really shines when you have these last pieces. Again, without using any ultrasonic energy or vacuum, just with irrigation, you can just position the instruments around the lens pieces and crush it over and over and over again. Because I do this all the time, I've become really, really good at it. And so because you get good at it, the risk for complications is really low. You're very efficient with the lens disassembly. And again, the chances of wound burn and post-occlusion surge and posterior capsular rupture is really minimal. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. Again, you can see there's no epinucleus. There's hardly any cortex. And so I'm just removing some of that peripheral wispy lens material. Again, with the dense lenses, I'm always concerned about zonulopathy. So I switched to polish mode, polishing underneath the rexus edge. You can see some fine stringy things. I'm polishing the posterior capsule as well. You might see some stringy things, but it might be attached to a bigger thing in the capsule fornix, which you can't see. So it's important to go after that stuff, because if you ignore that stuff, what'll end up happening is you'll be that patient that has that giant Sommering's ring, and you're wondering, golly, why is all this stuff in here? And that's because you didn't polish deep into the capsule fornix. Remember, you can't see that. So if you only remove what you can see, you're going to leave more lens material than you think you did. So I'm polishing the subincisional posterior capsule as well here. And what ends up happening is these posterior adhesions, like I said, are attached to the forniceal adhesions. So by removing the posterior capsule adhesions, it allows me to more effectively peel the stuff once I get in with the polymer tip in the polish mode into the capsule fornix. So I go ahead with the cannula and I'm pulsing the subincisional capsule fornix. And because I loosened that stuff off the posterior capsule, look how much crap starts coming out. I'm able to add that stuff. And again, that's because I peeled off the material that was stuck to the posterior capsule. It provides a more effective way to get rid of that lens material that's stuck in the capsule fornix. Pushing cohesive viscoelastic to fill the bag. And then I'm polishing under the rexus edge, sweeping with the sweeper, removing the lens epithelial cells. And again, if I felt like there was more lens material, I can sweep a little bit deeper into the capsule fornix to pull and peel really stubborn lens pieces out of the bag. And remember, with these super dense lenses, I always like to put in a 3-piece lens because I do think there's a high risk for zonulopathy. And long term, if there's a problem, I want to be able to use that 3-piece lens if possible to reposition the lens if it's trying to dislocate. I'm switching to the cohesive viscoelastic cannula so I can fill the bag a little bit more. I go in with the 3-piece lens, pointing the barrel to the left. The leading haptic goes into the bag. Rotate my wrist so the optic comes out flat. The trailing haptic is out of the bag, and using the Maltzman to dial the trailing haptic into the bag. Perfectly well-centered lens. These are the nice things about the 3-piece lenses. They kind of center on their own. You go in with irrigation off, activate irrigation, get underneath the lens, tilting it, removing all the viscoelastic from within the bag, polishing underneath the rexus edge once again, making sure there's nothing stuck there. There's some subincisional crud that's stuck still, so I switched to visco mode, removing that material. Since the lens is there, it also protects the posterior capsule as well. There's still some stubborn material, so I switched to polish mode and polishing into the subincisional area once again. And then once it's free, I'm able to switch to visco mode, removing the lens material with that high vacuum. Again, I'm willing to do this in this context only because the lens implant is there and it protects the posterior capsule. Removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a super dense lens, hypermature cataract, Catarock. I perform terminal chop, again, by debulking the central core. This reduces the risk for a posterior plate. And then you don't want to crack from the top like the standard stop and chop. That makes no sense to me. It never did. Because if you're cracking from the top, it's like trying to crack Pac-Man's teeth. You want to crack his jaw, which is in the back. And so the way you do that is you get out to the periphery and you fracture from the terminal side. And by fracturing from the periphery, you're able to get a fracture point that involves the posterior aspect of the lens. And because there are lamellar fibers, that fracture propagates through and through, and you get a complete chop every time when you perform this technique. And then you saw I did cross chop, which I was able to place the chopper around the right heminucleus, pulling it centered toward the phaco tip, fracturing the lens against the phaco tip, which is deep in the bag. And I do this over and over again to remove those lens pieces. This is a very controlled way where you can fracture the lens from any different angle. That's why cross chop is so versatile. But again, you have to have confidence to place that phaco tip deep, and then you're able to get a complete fracture. And then you're able to just crush the lens into smaller and smaller pieces, emulsify the lens pieces. This patient had a very clear cornea post-op day 1. The patient was very happy. You can imagine going from blindness to great vision immediately after surgery. There's minimal endothelial cell damage when you use less ultrasonic energy. I'm effectively able to avoid getting corneal wound burns with these dense lenses and also avoid the post-occlusion surge because I'm never using super high vacuum when I have occlusion. I'm fracturing the lens into smaller and smaller pieces and then pulsing and feathering my petal. So I never get high vacuum, therefore I never get post-occlusion surge, and therefore the risk of posterior capsule rupture is much lower. This is a much more controlled, methodical, systematic way to disassemble the lens. And this is why I think this is the best way to do cataract surgery, and I recommend you try it as well. So I hope this was helpful to you, and I thank you for your attention.